Good afternoon, friends. I just had a phone call. What is that? This is the hospital in Bangalore taking reports online. He has just done an echo. Patient is waiting there, and I've sent him the report already. For distant echo, I give a report in an hour's time. So that's a new software that we have created, and in that software, I give a report right from wherever I am, within an hour to the patient. By the time patient dresses up and goes out, he'll just type the report that I have given and work on it. He only sends the videos and he gets a report immediately. This is a beautiful software that I have done, first time in India, and perhaps it's one of the rare software to report echo, because a lot of physicians are scared to report echo themselves. Okay? Carry on to you. Over to you, sir.
Yeah, so I think that is the need of the hour, because now without echo, it becomes very difficult to treat a lot many conditions. And gradually, as we are seeing, the good old stethoscope is being replaced by the echo probe in majority of the tertiary care centers. But in peripheral centers and in small clinics, still we have to rely a lot on the clinical skills of the individual, which may vary. So I think this is important. In advances in echocardiography or the echocardiography workshop, as we had a discussion briefly with Naik sir, we would like it to be a two-way session, because there is a lot of thing to speak on echo. We are all doing echo, I'm sure. So if anything specific that you would want to learn, feel free to ask questions, and we can skip some slides and go to that slide wherein the information is there, because otherwise it will become a mundane lecture, and we are not here for a mundane lecture. We are here to share our knowledge, because we understand most of you are also doing reasonably good number of echoes yourself. So with that, I think if Kinor has to add something, or we can go ahead with sir.
Why don't you all sit here so that I have an eye contact with you here? You're sitting so far as if I'm giving a big lecture. I'm not a lecturer. All my academics is my own creation. I'm not joined to any medical college. Okay. The first thing, number one today, your echo is not just an analysis of your heart or your chambers. Those days are gone. Today, when I put my probe on the patient, this is as a light joke, I can tell the patient, you will survive for such a long time. Take it as a joke. Okay, I can't tell the patient that way. Okay. So today's echo makes you understand what you are doing, not just on your heart, but complete metabolic status of the patient. And as a physician, this is what you want. This is what I have studied as a physician. I've studied echo, of course, 30 years back when echo just came in, but then I'm concentrating more onto that itself. As a physician, what do I want? So my patients, I've even created a different position for the patient. I sit with my scope here, my patient sits here, and he looks at it. So I finish most of my consultation as I do the echo with the patient. You can tell him exactly what is happening. At that time, you can explain to him exactly what what has been happening to his body, and what he should do ever since, so that he lives a complete life. And that life of one of my first book is that I wrote published 10 years back, 2010, was Alert, Active, Alive at 100. I am a longevity physician, and I've got patients living up to that stage. In Goa, we've got about 26 people living beyond 100. Okay. So that's the way I want you to use the echo. And I would say every physician, before he writes a prescription, should put a probe on his patient and see exactly what the echo, what the heart is. Okay. So my purpose today was, of course, advances in echocardiography. But as I understand, most of you are physicians doing echo for yourself. You're not doing echo for a hospital who needs to be operated. So we have to be restricted to a little, at a level where you need to be. Okay? So in that case, we've got a lot of subjects to, Dr. Kamaldeep has given me so many subjects: mitral valve, stenosis, regurgitation, aortic valve, stenosis, regurgitation, and your tricuspid valve, stenosis, regurgitation, and your diastole, and your ischemic heart disease. Okay. So I know you know that each one of them are lectures for hours together. But let's go through them nicely and make you understand. I'm sure once you go from here, you will go with a better eco knowledge rather than just an academic knowledge, because that's what you are going to do with your patients. Okay. So let's see this. Okay. Now, how do we do echo? We started with M mode. We started with 2D echo. Then we started with pulse and continuous wave Doppler, color flow Doppler, tissue Doppler. Then your transesophageal echocardiography, especially happens in your OT. 3D echocardiography, which is getting pretty prominent now. But unfortunately, 3D echocardiography doesn't help we as physicians. It does help a surgeon who operates on the patient. Then the most important thing, take it from me, you can forget everything else. Start doing strain imaging. And you will understand all that happens to your patient. With my expertise in strain imaging has helped me to find a lot of patients going into myocarditis these days, whatever is the cause. And I have managed to save all these patients who have been coming with chronic fatigue syndrome, who cannot do anything. You'll be shocked. One of the patient's mother got all right, and then her daughter, who's in UK, came down for 15 days just for that treatment, was completely down with chronic fatigue syndrome, and she could go home absolutely fresh and fine. So this is what that strain imaging has taught me. Your stress echo, you can do. I don't know how much it is of help. It is of help to some extent. Contrast echo is, in some cases, very, very good. And most of us today are going in for hybrid imaging. We all have a good MRI giving a good report on your heart. And now with AI interfacing, echo is going to be your, as I would say, live. Echo is going to give you your tachycardia. Echo is going to give you the pleasure that you want out of that little instrument of yours. Okay? Now we are taking we have got various things. How do we do is, yeah. Mm-hmm. Okay. Day after tomorrow.
So the lecture is day after tomorrow, but the demos will start tomorrow itself.
Okay.
And we intend to put it for our physicians and see their scoring and make a database out of it.
Online? I would be very interested in seeing that, but day after tomorrow I'm going early in the morning.
No, it's for everybody, so just wanted to briefly know about it. So
I would be interested.
The device would be first time launched in India.
Okay.
Very soon.
That's great. Let me go to the So these are the things we are supposed to be doing: mitral regurgitation, mitral stenosis, aortic valve, and tricuspid, diastolic function, coronary heart disease, okay? I've been told let's start with coronary heart disease, and the rest of them we'll give 10 minutes each, okay? Right? For you, this is all. This is everyone's bread and butter. This is a coronary heart disease is not your just bread and butter. It's what you must be very, very good at. Very, very good at. And I'll tell you what you have to be good at. You don't have to be good at all the details which are there into it. Okay? There are a hell lot of details inside this. Okay? Your coronary artery disease. Okay? Your segmental approach, basal, right? Middle, mid segments, and apical segment. Basal, you will see the mitral valve. At the mid level, you will see the papillary muscles, and at apex will be beyond papillary muscles. Okay, and if you take two, I'll show you. Okay, now let us see this. This is your short axis. Okay, right? If you need me to tell anything, don't just get lost. Okay. Let's have some basic, but have it fully into your mind. I'm not going to tell you too many things, but I'm definitely going to tell you what you need, okay? Because that's the way I have come up in my practice. So this is your short axis view. This is your septum, this is your left ventricle, this is your right ventricle. This is your anterior septum, this is your inferior septum, this is your inferior wall of the heart, this is the posterior or posterolateral. Basically, we put it as posterior. You put this as a lateral and this as anterior wall, right? So here you know basal, mid, and apical segments. Now, in apex, what happens? In both apices, anterior and inferior are fused into septal. So it is 6 segments, and 4 segments. Okay? So it is septal 1, and you remove the posterior from the at the apical level. So it is 6 segments, and 4 segments. So 16 segments. And now many times we make a 17 segment, which is just the top of the heart, the hat of the LV. So that you consider it as a 17 segments, whichever, and many times this becomes very, very important. I reported just now one patient who had 27-year-old who had only a selected apical hypokinesia. Okay, so if you see 4 chamber, what do you see? This is lateral wall. This is the septum. Okay, so when you see 2 chambers, this is your inferior wall. This is your anterior wall. Okay, and your 3 chamber, this is your posterior or posterolateral, and this is your septum. Okay, you're seeing this every day, and this is what we need to. Okay, and this is your bullseye. All segments put together, and this is the apical segment that I will show you. Just at the apex, many times you have to really look at apex very seriously. This 27-year-old boy having an apical infarct only indicates that his coronary circulation must be getting hampered everywhere. It cannot be a selective one. Okay. All right. Are you with me up to here? Once you understand this, rest is just put it in your mind. Don't go home and try and study. Just concentrate everything onto this. Okay. I will not take you into this. I'll not take you into this coronary supplies. And now, when you look at your ischemic heart disease, what do you look at? The first thing is remember two words: thickening, thinning, and no change. Thickening is important. Systole is thickening of the myocardium. Thickening of the myocardium. See, heart keeps on moving. So you feel your myocardial wall is moving, but it's only when it is thickened, thick and thin, thick and thin. Systole, diastole, systole, diastole. Put this one word inside your mind, and this is what your eyes have to see. Which part of the heart is thickening? Once it is thickening, then you know it is thickening normal. Then you know it is thickening less, hypokinesia. It is not thickening, akinesia. Or it is going out, that is dyskinesia. Just these four words: normal, hypokinesia, akinesia, and dyskinesia. Once you remember these four, forget about so many other words that we keep, echocardiographers like to keep on. Most of our echocardiographers say this is our echocardiography, cardiology language. I don't want that. I want your patient to get the perfect treatment from you, okay? First is your myocardial thickening, then comes your wall motion, okay? And then comes hinge point. What is hinge point? At what stage, at what point it is not moving, or it starts, it is abnormal. That is your hinge point, okay? Then ventricular shape is important to you. A normal ventricle which is like a bullet shape, once it has got some ischemia somewhere, it will definitely have a change in its shape, and start looking for that change in the shape. Okay? Then in simple word, what you call it as remodeling. If you have a heart which is remodeled, that means somewhere it has some ischemic segment. Okay. And echogenicity. Your heart has a particular echogenicity, start comparing with the others. Then when it is fibrosed or necrosed, it becomes white. All right? This side, so it becomes white. What is white? Fibrosis. That segment is already dead and it is fibrosed. You have to prevent that segment from becoming a dyskinetic segment. Okay? Can you put this in your mind? I don't think I need to explain you to all this. There are situations, there are people who fall into this hyperkinesia group. These are young sportsmen, okay? Very anxious people. They can go into the first stage called hyperkinesis, but now second picture is normal. Third picture, you see the top of it, this portion which is a hypokinesia, this portion which is akinesia, and this portion which is dyskinetic. Okay? Do you get this in your mind now? It's okay? Hey, what happened? It's not moving. These are not moving. These are videos. These are video. Is it a video? All are videos. Okay, let's go a little further and see. Okay. This is your anterior wall myocardial infarction. This should move. Do you have a pointer? Do you have a pointer? Pointer? Pointer, sir? They are all only videos, all are moving pictures. Go further and try. This one is video? All video. There you can see this. See this. It has to move, huh? It has to move. Pointer कहाँ है? Pointer कहाँ है? This. Yesterday I've gone through all the checks. Everything is moving. Na? This is important. Everybody, na?
So I think till that time, I would like to talk about a real life scenario. So let us say, say 55-year-old gentleman who had a 6-month-old anterior infarct and echo is 30-35% EF anterior territory. Now the angiography is suggestive of mid-LAD total occlusion retrograding from the right system. The right system also has around 70-80% disease and the circumflex has around 90% disease. Whether to revascularize the LAD or not, we would get some ideas from the echo, and that is what we saw. So if that LAD territory, if that LAD territory is thinned out, it is white, what was written. If it is thinned out, it is white. And then you may, or it is dyskinetic, you may say that it may not be viable. And sometimes multi-vessel angioplasties or multi-vessel revascularization becomes a single vessel revascularization depending on the viability study. So echo is a very crude way. It is not 100%. The sensitivity would vary from 88 to 92%. But broadly, if your IVS thickness is less than 6 mm, see normally we know it's around 10 and 11. So broadly, if your IVS thickness is less than 6 mm and it is shiny white, you can safely suggest that this may not be a viable territory, should not waste your time, energy and money after revascularizing a dead territory. Of course, you should supplement it with either a perfusion scan or a MRI. MRI has the best sensitivity to depict a non-viable myocardium. But what was mentioned over here, the shininess is very important. So if it is a very hyperlucent territory, it means that it's a dead fibrous tissue. So that is where clinical implication of this would happen. Again, my one question to sir would be, many a times when the patient comes in the first few hours, you know, the ECG is more or less okay. Maybe I would say there are some changes. You may say both of us are right. The troponin would not be positive because the period is not 6 hours and above. And the echo. Does, sir, I was just talking about a scenario wherein a patient
Recording in progress.
where the patient comes in within, let us say, less than 6 hours of chest pain to our clinic. The ECG is borderline. The tropes may not come positive. And the echo, again, not very convincing. Would a strain help? Of course, it is a later up half of the discussion in this.
Be a master in strain. Strain is wonder today. Okay? It's wonder today. I don't do an echo without strain. It takes time. Patient, sometimes I don't charge anything extra for strain. Okay. But every patient, you get surprised. Okay, that there are so many different patches with low strain where you can pick up, like a 60, 70-year-old heart. It will have so many small patches, small arterioles, the arteries which have been blocked long time back. But if you see the whole thing, you don't. Like once you get an acute myocardial infarction, there are at least 20% of the time you will get a normal ECG in the first few hours. At least 2% of these patients will go out with a normal ECG, but with a complete heart. with a proper heart attack. Okay? At this time, strain is very, very simple. And once you start doing it, you will start doing strain in, I'll show you some strain images, okay? You will start doing strain very, very regularly because you will pick up what you have not seen. And the most important thing is in hypertension. When you have a patient of hypertension, do not send him without a echo. The first damage blood pressure does is on your heart, isn't it? Because it's a pressure inside your left ventricle, okay? And by the time you see it in an echo, you need at least a left ventricular hypertrophy to say that hypertension has affected the heart. Before you see the left ventricular hypertrophy, you will end up in seeing a low strain, especially at the base of the heart. This is very, very classical. Low strain at the base of the heart, which is an early hypertensive damage to your heart, which I'm able to give it to the doctor. This is hypertensive heart. And please treat his blood pressure first rather than giving him statins and aspirin. Okay? So statin is I would say, the way we should do. I've forgotten most of the things now. I don't even need them once I do a statin thing. And then what happens? You get once you do a strain pattern. And what happens? Once you do a good strain pattern, you can show the patient. Patient can see it because now we are able to color the pages. Na? Patient sees this. Ye red hai, yahan to damage hua hai, ye green hai, this is perfect, this is 20 marks, 21 marks, 15 marks. Your patient goes, accepts your opinion stat on the dot. So start doing statins, start doing strain. Okay? I know I talk too much about statins. I'm not an anti-statin, but I don't use statin much. So, and everybody keeps on asking me about statins. All right? So in your perfusion condition, you have ischemia, you have necrosis, you have stunning, and you are hibernating myocardium, okay? And if you are good enough, you will be able to say yourself, this is a stunned myocardium. This is a hibernating myocardium. What happens in stunned myocardium? The size, the thickness will remain the same, but the contractility will not be there at that time, or at the most a very low contractility will be there. And when you are looking at your heart, you can pick up. This is an infarct, and this is a patient is in stunned stage, or this is the myocardium which is hibernating. I'm telling you, sir, your echo can show you this, especially when you become good at our strain pattern. Okay. All right. These are the various stages of ischemia. I'm not going to confuse you with that. All right. In acute stage, you also get remember there is also a perfusion edema. Okay. Whether you call it a stunned myocardium or later on. So you have irreversible damage, 3 to 6 hours, fibrosis, scar tissue, and then akinesia. This is stunning. I won't go much detail inside it. Just give a glance over this picture now. This is a normal. This is normal. Then you have mild ischemic. Okay. Then you have a proper ischemic segment. Then you have necrosis, thin, and then you have hibernation and stunning. Okay. These are a little thing you need a little practice to understand that. And you can easily get it because you know this is the place where you have an infarct. You know what will happen around that area. Okay? And put this little knowledge into your picture. Over a period of time, you will be very, very good echocardiographers. remodeling. As the myocardium gets damaged, there's a progressive dilatation, especially eccentric eccentric left ventricular hypertrophy, and there is a distortion geometry. And remember this word, remodeling. Most of our echo books do not talk much about this. If this, you know, this is my ventricle. So if this ventricle has become this way, something has gone wrong somewhere, which you have to sit down and see. Which you have to sit down and see. And you are able to see it well. And then this kinetic segment will become aneurysmal segment tomorrow, okay? Which you can easily identify, okay? You have to identify two things. One is a real aneurysm, wherein all the layers jet out, and your pseudoaneurysm. What is pseudoaneurysm? Where there's a rupture, and then blood comes out. Pseudoaneurysm is covered externally only by pericardium. Okay, that becomes a real emergency, especially after acute myocardial infarction, in the initial phase of acute myocardial infarction. Okay, nice picture for aneurysmal. How you all have got remodeled yourself. These are scar, dyskinetic. Okay, I'll go through this. Subendocardial scar, transmural scar, viable and non-viable myocardium, okay? Okay. Now this look at this. Okay? Where is the infarct here? LAD, right? Look at this. Here there is an aneurysm and there is a scar tissue. Okay. This is a stunted left ventricle. And this is your inferior wall hypokinesia. Your LVO, your function of your left ventricle, there are various methods that you are going to use, okay? And let me tell you, ejection fraction does not mean the heart is okay. And ejection fraction is not the only criteria for functioning of left ventricle or even for systolic function. Understand how our heart contracts? Like your towel, na? It has got a longitudinal contraction, a circumferential contraction, and radial contractions. All three things happen together. And when all three things are disturbed, then the heart in a particular way starts getting remodeled. Okay. This is your 3D. And your left ventricular ejection fraction, of course, your Simpson method. And after that strain, nothing to beat the strain pattern. Many times we have to use contrast. See this. In the contrast stage, I jumped back. Many times, see how well this segment can be shown. This is a normal segment, this is the ischemic segment. Many times, especially lateral wall, you do not get a proper view in most of the patient, okay? Some very special thing you have to look at is supraapical region, lateral region, and basal inferior regions, okay? These are the regions where you have to concentrate a little bit more to understand the contractility at this stage, at that stage. Okay. There are, and do not forget that there are many more conditions like your LBBB, dyssynchrony, pacemaker, wherein the segments are not contracting properly, and many times you end up in saying this is a dyskinetic segment. Okay. And today, lots your myocarditis have increased in number. Start looking after your myocarditis patient, and that will surprise yourself. And of course, cardiomyopathy. These are the conditions. Many times you have to rule out these conditions. You have to have your patient's history, his BP, and his ECG before you sit down with your patient for echo. Even when you are a real expert in echo. Takotsubo, you know what is this condition is, na? This is because of a hyperadrenergic state or stress cardiomyopathy. It was supposed to be transient. I've got patients who are permanently suffering from it. Okay, okay. And this patient, you can see there is even a LV clot there, big LV clot which is getting organized. Okay, I'll not go through all this. Let's drop out some of this. These are small spine infarcts at every stage, large anteroseptal infarct. Okay. Ischemic heart disease is a beautiful echo study. Complications, your cardiogenic shock, myocardial rupture, ischemic VSD, and papillary muscles. See that right heart, there could be a right heart infarct, thrombus formation or mitral regurgitation, and that remodeling of your heart. Once you have a cardiogenic shock, you know. Myocardial rupture, pseudoaneurysm, just a picture. I'm just giving you a quick glimpses of all this. Ischemic VSD, a lot of people have, and a lot of patients have died when they are about to be discharged at home. So your cardiac patient will have many more things besides a block. I know somewhere in our country, especially our side, for any chest pain, block is the only answer. Any chest pain, they will do an angiography, put a stent there and send the patient home without seeing that patient has got many more things in his heart. So start looking at this. Many times it is difficult to actually see your wall motion abnormality, okay? But look at the aneurysm, rupture, mitral regurgitation, papillary muscle rupture, ischemic VSD, thrombus, okay? And patient going into shock. Just to summarize all these things for you. Look at some of these pictures. Look at this picture. This was a doctor who came to me last year. I've explained to him at that time, you have ischemic heart disease. You better go ahead and try to work on this properly. He did not care. He was an Ayurvedic doctor. Okay? Now this time, he came again with this heart, with an extensive LAD block. And when he came, his ejection fraction this time was, this was day before yesterday. Okay, there is a date somewhere. 20, this is 9/7/24. And that was just 1 year in advance. See the amount of knowledge, information that you can pick up with your strain patterns. So that particular conal thing is a very classical thing of an ischemic problem. Okay. This is another thing. This is ischemia with hypertension. This is pure ischemia. Again, LAD ischemia. This is again the anterior wall ischemia. These are some of the ischemic patients. This is a hypertensive patient. Look at this. A chronic hypertension, it begins with reduction of strain in the initial stage, then second stage is hypertrophy, and then subsequent other problems. This is also an ischemic problem, toxic myocarditis cases, okay? So this is a young boy, and he has he has no complaints, no symptoms, only a chronic fatigue syndrome, and you see the patches that he has. This is myocarditis patient. This is again myocarditis patient. Okay. This is not an ischemic patient. This is a myocarditis patient. This is an hypertensive patient. This is diabetic cardiomyopathy, no hypertension and no ischemia. Coronaries are normal. This is a diabetic cardiomyopathy. Okay. It's so easy to find out, to understand what exactly happens once you sit down, and I use a simple word. No, forget about knowledge. Sit down and start seeing your heart. Start seeing all the small condition in your heart, and you can right there show this to your patient, and that patient will never ever leave you. I think I've spent a lot of time onto this. Okay.
Sir, how you differentiate the RWMA of Takayasu compared to the LAD infarction? Because sometimes it becomes very difficult. Both will involve the mid LV and apical LV segment.
No, so I didn't understand, sir.
How to differentiate the Takayasu cardiomyopathy versus LAD infarction?
Okay, yeah, cardiomyopathy from this. Okay, Takotsubo, it's named after that vessel, you know. So this, it starts contracting, and this is not contracting. Okay, because this is a hyperdose of your catecholamines. Yeah. Okay, your base contracts very well, and your apex does not contract very well. Okay. Well, just on one echo, you can't say it is Takotsubo. Okay, then you have to see the patient. And then you will always ask this patient for a coronary angio. Yes. And then you will get your normal coronary angio. Then you will label it as Takayasu. Okay?
So to diagnosis, otherwise. We need to do the angio. Yeah,
you will always do it, because this is a serious problem. Okay, many of them do recover, but not all. I've got a few patients who are really bad. Yeah. Who after the 7-8 years still have 20-25 ejection fraction. Okay, so don't just take it. Takotsubo is a diagnosis which is not to be thought just offhand. Okay, but remembered that you have a coronary artery angiogram which is completely normal, and you have a bad heart. They will go into hypotension, they will go into clots, they will go into emboli, all sorts of things. At that time, all sorts of things, including ventricular fibrillation.
How to differentiate the hypertensive heart disease and diabetic cardiomyopathy on strain imaging?
Okay. Now, first of all, you start with history. Okay. In strain imaging, there is not one sign. These are metabolic cardiomyopathy. Your hypertensive patient will also have diabetes, and vice versa. So you keep on going down to them through the history. Okay, this man has been having a long history of diabetes, short history of hypertension. Okay. Now, what happens as you see this? I've never been making a diagnosis of diabetic cardiomyopathy often. Okay. So you start seeing this, and then especially If base is, only base is affected and all others have almost 20 strain, then it goes more in for hypertension. But diabetics is very selective. There is no specific sign of a diabetic. What happens in diabetic, initially muscle gets inflamed and it swells up. Besides the diabetes have microvascular diseases. So you have more than one patch, which is usually not there in hypertension. Then one patch of, I would say, redness, or one patch of low strain. And then there are other things like a diastolic dysfunction. In hypertensive, you will get diastolic dysfunction after the patient has gone into hypertrophy. Here, hypertrophy may not be that much, but young patient is with diastolic dysfunction. Maybe grade 1, grade 2, even grade 3. Okay. So at that time, you have to put your discrimination, and even now I put a diagnosis, query could be diabetic cardiomyopathy. How do you say it is myocarditis? You rule out everything else and then say it could be myocarditis. I don't give a diagnosis of myocarditis. I put a query there and give a diagnosis of myocarditis by ruling out all other things.
See, basically clinical plus the echo, if there is a generalized wall motion and the patient profile does not fit into a classical ischemic this thing, but still you have to rule out ischemia before saying that it is myocarditis, unless in the times of COVID or fulminant viral endemics, when we know that this could be viral myocarditis. Regarding strain, it is not very big or difficult thing to do because most of it is done by the machine. So when we say strain, people will feel that kuch aur nahu kasu sikhu par se, vachu par se. Nothing great about it. The machine does everything. You just put a cursor there and you switch the strain button, you get the strain. And we have been saved a couple of times because in young patient, I was telling you the scenario wherein the ECG was okay, the echo was okay, but the strain was positive and he had an LED infarct in the early stage. When the patient comes to you within the first 30, 41 minutes, 1 hour of the pain, the strain going down may help you. Another thing that normally ischemic heart disease patients on follow-up, I also like to look into the E by E dash, which is a measure of the wedge pressures. So during a follow-up, if the patient is having a chronic fatigue syndrome vis-a-vis a volume overload, vis-a-vis a COPD element, it becomes very difficult to adjust your medicines when the patient say thak lage che or chalu chune ek pagotyo chodu chune. So is it heart failure? Is it pulmonary COPD? Or is it just a chronic fatigue syndrome? So here, E by E dash rules out or rules in cardiac. Whether you need to give a diuresis or not, E by E dash is a good. So in coronary artery disease screening, when I send my patient for screening, these are the 3 points that my echocardiographer has to look into.
Please, I'm a physician. So what I talk to you about the echo is from the mouth of a physician. Take your patient, take a good history of your patient, understand your patient, make your tentative diagnosis, assess the ECG, and then put your patient for an echo. You will also start going on a better track. You'll also start understanding your patient better, and you will also start managing your patient better. Because all your patients have multiple problems today. They have multiple problems. Okay? So let's not, especially when it comes to ischemia. All other diseases, okay, specific diagnosis. Your valvular disease is a specific diagnosis. But the ischemic is not just related to your blockages. Ischemic is equal to not blockage. Let's throw that idea out of our mind. Now the interventional cardiologists have stopped doing echo. Why? And they've stopped sending it to me. आप उनको अच्छी diagnosis दोगे, patient will say, I'm getting okay. So start understanding your patient, and I'm telling you, you will enjoy it. You'll just enjoy. That's the only part of my job which I just enjoy. Sit down with the patient. How do I sit down with the patient? My machine is here. My patient, most of you, what do you do? Put the patient on the other side and do your echo like this. Your hand gets cramped. Okay? Patient is looking at a dead wall. At least put some nice, if he's a man, put some nice girls' pictures there. Okay? He's looking at a dead wall and he's just wondering. Many times you don't get a good window, you struggle a little bit. At that time, he worries. Kya ho raha hai? Doctor Saab, is my heart this bad? So what I do is put my scope here, I sit down here, put my patient here, his face here, you look at your patient, you look at your heart. 1, 2, 3, 4. And I'm telling you, that's the best part of my practice. To show them what they have and explain to them. At that time, you can explain to them. Then he comes back with the report to you, and then you are nowhere. Okay? So as a physician, that little echo machine is a big advantage to you, and start developing it. Start growing into it. The number one, it will increase your income. Okay? You'll definitely charge some more for your echo. And if you do 2 echoes a day, you will repay for that machine in 6 months' time, to maximum 1 year time. So let's all get a nice, good, decent machine, which gives proper strain. And then sit down with your patients. You will always enjoy your practice. Okay? Now I think I've almost finished an hour. Another half an hour is what I've got. So what we'll do, let's go to diastolic function. Yes. All right? Anything about ischemic, that is your bread and butter. Even if you learn ischemic, you're good enough with your patients. You're good enough in your practice, and you'll enjoy your practice. Rest you forget. If you can say mitral valve, whether your stenosis is mild, moderate, severe, regurgitation mild, moderate, severe, only those patients who have got severe regurgitation or severe problem, those are the patients which will go to a surgeon. Those are the patients which you as a physician should not sit down with. Unless surgeon gives up, he says he cannot be operated or he is beyond the surgery. All right? So what do we understand by diastolic dysfunction? What do you understand by diastolic dysfunction? Let's talk here. I'm not come here to give a lecture. What do you understand by diastolic dysfunction? What is diastole? The feeling phase of the left ventricle. Okay? This is okay? This is your diastole from T wave to beginning of QRS complex. All right? You multiply your diastole into isovolumetric relaxation time. Your aortic valve closes and then the ventricle starts relaxing till the mitral valve opens out. That period is your isovolumetric, volume is same, relaxation. Okay? And then your ventricle will relax further, and first thing it will suck out the blood from the atrium. So that will be the rapid filling. How good is that power of your left ventricle will decide about the feeling of your left ventricle. And that will decide about that E wave. Big E wave indicates that most of the blood is filled during the initial phase of the ventricle relaxation. That is a normal ventricle. When that feeling, and then there is a time when the pressure across atrium and ventricle stabilizes, becomes one, and that is your diastasis. And at that time, there is still some blood left in the left atrium, where the left atrium contracts and pushes this blood into your left ventricle. Okay? Now the problem here comes when the ventricle is not strong enough to accept this. So diastole is ventricle's problem because of so many other things. So your ventricle has got an elevated pressure, or it is not able to suck in the blood properly. Okay, so this is your first thing. This is your atrial contraction. This is your E wave. This is your A wave. This is your diastole. This is your IVRT. This is the diastasis, and this is the next phase of aortic valve closure or systole. Okay. So now only thing, if you understand, forget about this is a complex, it looks like a very complex picture, but the picture is that you have a problem in relaxation of your left ventricle. And if you have a problem in relaxation of your left ventricle, and if it goes further, becomes more and more and more, you, without your coronaries getting any problem, or without your systolic, your ejection fraction being normal, you will have a left ventricular failure. So here is a place where you have a normal ejection fraction and you have a failed ventricle. Okay, so this is your diastolic failing, or what do you call it? Left ventricular failure with normal ejection fraction. Okay, if you remember this, I think that is enough for our practice. And then the next question that you get is, how much is the diastolic failure of the left ventricle? Grade 1, normal, grade 1, grade 2, grade 3. If it is, and grade 4. Once it comes to grade 4, you know the patient needs something to be done very, very urgently. Okay? This patient should not only remain in your hand. All right? So I don't think we've got time to go through all this. Okay? So how do you assess the diastolic function? First is your mitral inlet Doppler, M wave mitral Doppler, then your tissue Doppler. And if you start doing this, even I don't do the rest of the things. It is just for, we don't even need that unless your windows are that bad. Okay? And so this is the first thing. So you put your, what do you put? These are all the normal values. You put your okay. Let me go back. I think I need to tell you a few things. You will put your Doppler here, and you will do a mitral inlet Doppler. Okay? You will get your E wave, you will get your A wave. All right? And if there is a diastolic dysfunction, there will be alteration in this E and A wave. Okay? To put it in more and more simple thing. E wave, during E wave, there will be less blood going there. During A wave, whatever blood is there, the left ventricle will push it and it will go down into the ventricle. So E will become smaller and A will become larger. Okay? Anything can give you, any cause can give you a diastolic dysfunction of the left ventricle. Okay? These are the various causes which I have put up there. And the moment there is a dysfunction, this patient is in problem. If it's a mitral mild dysfunction or grade 1 dysfunction, we usually don't care. After 60, all of us will have that. So as the dysfunction increases, patient is going to be bad. So once you have a left ventricle which is stiffer, okay, it will increase the pulmonary artery pressure and it will give you breathlessness, leading to HFnF, heart failure with normal ejection fraction. Okay, so now at this stage, the elevated feeling pressure in the left ventricle will go and get affected right up to your lung. So these are all the details. I know it's a very, each one of this should have been very separate. Okay. Now look at this picture. Look at this patient. Okay. What do you see in this patient? There's a left ventricular hypertrophy, and in your systolic strain, the strain is reduced. Patient is in failure. But if you look at this patient, he looks great. Ejection fraction is almost, if you see visual ejection fraction is more than 70. It's a very strong ejection fraction because the left ventricle is hypertrophied, okay? So this is your mitral inflow pattern. This is the early feeling. This is atrial contraction. Let me tell you, relaxation of ventricle is not a passive phenomena. It's a very active phenomena. We'll have to talk quite a lot on that. Just take it. It's an active phenomena, okay? It has to relax, okay? And all those problems which are around it will lead to an improper relaxation of the left ventricle. This is the twisting and untwisting of the heart. So mitral valve, early filling, atrial contraction. So when it is some of the people can have a supernormal where the suction is so good that the whole blood, almost most of the blood, gets into the left ventricle. In that case, you will get a feeling like this, which may be something like a grade 3 and grade 4 type of left ventricular failure. Okay. So first thing, it is a compliance, and then the left atrial and left ventricular pressure. It is the interplay of all this that gives you the various stages of left ventricular failure. Okay. I will not, because this will take me a long time through this. Early feeling is low and your late feeling is more. So I'll go straight further. Okay? How do you grade this? This is normal. E is bigger than A. Then this is grade 2 is abnormal relaxation of the left ventricle. That is, ventricle is not able to relax normally. Okay? And this is your E becomes smaller, A becomes bigger. Okay? Because it cannot relax, it takes much lesser blood. And then what happens, whatever blood is left, the atrium contracts and it fills up the left ventricle. This stage is, up to this stage is okay. Then it becomes pseudo-normal. Then stage 2 is pseudo-normal. What happens at that time? The pressure in the left atrium rises. And because of that pressure and poor sucking, the left atrium pushes in more blood. Okay? And it looks like a normal. E becomes like A, but you can see the deceleration of the downslope of E wave. Okay? And in the last stage, in the third stage, what happens is the pressure builds so much that all that blood is pushed into the left ventricle, and a very small blood is left for the left atrium to push in. Okay, so when this becomes in the initial stage, in between this, if it is reversible with your, what do you do? How do you change the blood flows into this? With your Valsalva maneuver. Okay, by changing the pressure in the atrium. And if it is reversible, that is your stage 4. So it is at this time, till it is reversible, you are able to do a lot of things to your patient. Bring him to a normal level and your patient can live his complete life. You can revert that. But later on, once it becomes irreversible, then you have a problem. Now, many times you still have a little bit of between grade 3 and grade 4 or grade 3 and grade 2, 3, and 4, you do have a little problem. Put your Doppler on the tissue. Usually I do only medial. You can do medial and lateral. Medial is more than enough, okay? And if the S wave, this is S wave, this is E prime wave. If this E prime wave is smaller than A prime wave, invariably you know you are facing diastolic dysfunction. And these various ratios, E by E prime 7 or E prime by E by E prime more than 15. Just remember one figure. E by E prime more than 15, that means you are facing diastolic dysfunction. All right? So does it make some sense? Is that enough for us right now? Diastolic dysfunction means ventricle is not able to receive the blood properly. By some means the pressure in the left ventricle is more, or there is a stiffness to the left ventricle. Okay, and then all these mechanisms occur at grade 1, grade 2, grade 3, grade 4. If you are facing a grade 3, like a complete dilated cardiomyopathy or a very bad hypertrophic cardiomyopathy, you will reach that stage. Or a very severe ischemic cardiomyopathy with the dilated heart, you will reach that level of grade 4. Once it reaches again grade 4, yes, your surgeon should try and help you at least. He may not be able to do anything depending upon the cause, but at least you are sharing your burden with your surgeon, because your patient is on his way to become serious. Okay, anything else you want? I just try to simplify it very. There are other things like venous blood flow, and then there are many more complex things to it. Are you going with a feeling that you can see whether your patient has got diastolic dysfunction or no? Otherwise, we'll have to go through all 4 procedures, which you can easily identify. First, see, you do a mitral inflow Doppler. If E patient is normal, has no problem, is less than 45, is E is taller than A, he has no diastolic dysfunction. Okay? If he has at this other extreme, he has a very severe heart and E is too big to A, 2:1 ratio, then he might be having grade 3 or grade 4 diastolic dysfunction. Okay? There you will push up, give him a Valsalva maneuver and try to see whether it is grade 4 or grade 3. Now, between grade 1 and grade 2 is what you have to take this little trouble to understand. Okay? And if your patient comes with a normal ejection fraction, I know all the surgeons and anesthetists everywhere ask you only one question. Iski ejection fraction kitni hai? And the patient has normal ejection fraction. If it is hypertrophy, you can still get a 80 ejection fraction. And the patient is in pure left ventricular failure, or even in pure congestive cardiac failure. Okay? So this whole process, they will call it as heart failure with normal ejection fraction. And that is a diastolic heart failure. I will not take you into all those complexes, because it will take so much of a time. I'm supposed to be finishing at 4:30, huh? 10 minutes more. If you have a systolic heart failure, you must have diastolic. If you have a systolic dysfunction, you must have diastolic dysfunction. This is always there. Okay? But many times diastolic dysfunction is there, systolic function may be normal. It may not be normal. Now, after they're doing the strain pattern, we have realized it is never normal. By the time he has a diastolic dysfunction, why the ventricle is stiff? Why the pressure in the left ventricle is more? Because there is a disease in your heart. So start seeing that disease. And so many, I just showed you quickly, I showed you what could be the various diseases in the heart. So, yeah, if you combine both these matter, mitral valve as well as your tissue Doppler, you are able to do it, but do it in more than 3, 4, 5 times. Okay, look at it. Some complexes are very good, where you can get the actually good reading. Some complexes are very ventricular contractions are very superficial because of the atrial rate. Okay, so at least do if there's a atrial fibrillation, do it in 4, 5 different complexes. Okay. What shall we do now? Go for some valvular thing. See, there are a lot of things in diastole. I'm just trying to quickly go through. I thought I would touch everything in 15 minutes. What else shall we go for? Aortic stenosis would be okay. Yeah. That is a hot topic today because we are able to help these people much in time today. Okay. I put on mitral stenosis. Sorry. Okay? Survival, if there is a severe aortic stenosis, you have an aortic stenosis which goes on for years and years, and one day it suddenly your patient collapses. Suddenly your patient starts worsening. This is the aortic stenosis picture. It's the third most common heart disease. Okay? And today, 30% of aortic valve stenosis is sclerotic. What happens? Hemodynamics, you have an increased tissue, increase afterload, leading to LV pressure overload, leading to LVH, and leading to increase in the filling pressure. So you will have LVH, you will also have a diastolic dysfunction. Again, when we are differentiating between pure diabetic cardiomyopathy, you may many times not have such severe diastolic dysfunction. Okay, so all right, when the left ventricular failure comes, it's because of the low output, because of the filling pressure leading to heart failure. There are two things here. Your blood cannot go out, so it is stagnating into the left ventricle. And then secondly, the pressure, the filling pressure of the left ventricle keeps on rising. So in one stage, you have a ventricle which is finding it difficult to fill the diastole, and in another thing, you find it difficult to throw out because the outlet is choked. Okay, so if you put these very simple terms there, I think you will be able to understand it much better, faster. All right, causes could be congenital. One of the commonest congenital is your bicuspid aortic valve. Okay, and now it's very, very common. Now we are all living a long life, and we are all going into calcified degenerated aortic stenosis. And rheumatic is also common in our country. If it is somebody who is less than 50, it's always a congenital bicuspid valve involvement. Okay, now you look at this aortic valve. This, if you see mitral valve, you know this is rheumatic mitral stenosis. Aortic valve is the second valve to get involved in rheumatic stenosis, rheumatism, and the third valve to get involved is your tricuspid. Usually, somehow, the pulmonary valve does not get involved that easily. Okay, but there are very, very rare cases described about pulmonary valve and rheumatism. Okay. This is a beautiful picture for you. I think if I show you some of the pictures which would be very, very good for us. Okay? Congenital, can you see the bicuspid aortic valve? This is the normal bicuspid aortic valve. When it comes to aortic, if it's a bicuspid aortic valve, a normal aortic valve, you have a valve pattern, your closure line will be right in the middle. When there is a bicuspid, the closure line is eccentric. So that itself makes you understand. Many times, bicuspid valve which is sclerosed is very difficult to understand, very difficult to analyze. Okay, but if you get a picture like this is one place where I use a mitral valve. I put a mitral line and find it out. Okay. Okay. You can see a beautiful bicuspid aortic valve. Eccentric closure, okay? See here. This eccentric closure, this line is always in the middle. In this case, this line goes little eccentrically. This should make you suggest that you are facing a bicuspid mitral valve, okay? Quadricuspid, I have not seen, but I have only seen the pictures shown by the others. Okay? And look at the various degrees of calcification. Okay. Now, right from mild, right from this is almost a normal valve. Here there is sufficient calcification. Here there is lot of calcification or moderate calcification. And this valve is almost completely calcified. Okay. So obviously you will see the third valve is the one which has to go in for surgery. So along with it, look at other features like your left ventricular hypertrophy will definitely be there. There will be remodeling. There may be reduced ejection fraction. And of course, look at this. Here there is a regional wall motion abnormality. Look at this. This is akinetic. This region is hypokinetic. Because by the time he reaches the stage of, look at the aortic valve, the sclerosis of the aortic valve, he has many more problems, including ischemic problems. Okay? Atrial enlargement will always be there, which is because of the elevated filling pressure of the left ventricle. Other echo features are diastolic dysfunction because of compliance, filling pressure, and also try and look at other signs and symptoms, okay? So this, what is this? This is the stage of almost grade 4 diastolic dysfunction or completely irreversible restrictive stage. Many times the calcification begins in the aortic valve. Most of the time, even by the time 40s and 50s, we find beginning of a calcification in aortic valve. And this calcification usually passes on to the mitral valve. It just continues, okay? So when you are seeing a calcified aortic valve, also put your full mind on the mitral valve and then compare these two things together and put everything together in a heart when you need to take a decision to make a surgical decision. Okay, can you see that color Doppler? Okay, how do you measure aortic valve? One is planimetry. And I hope it would have been so good if you could really make a nice planimetry, which is very, very difficult to make a planimetry in an aortic valve, the ease with which we make it in mitral valve stenosis. Okay. Because here this is all filled with erratic calcification. Okay. We have to measure the pressure gradient. Okay, and pressure gradient is V4 the velocity. So as gradient velocity rises, as your stenosis rises, you have a bad prognosis. Okay, these are your pressure which you get by intervention. See, when there is a stenosis, what happens to the LV pressure? LV pressure rises up. This is aortic stenosis. See the way LV pressure rises up, but at that time, initial phase, the aortic pressure still remains the same, and LV pressure rises, and there's a big pressure difference. This gives us all the signs and symptoms. Okay. So the velocity at the you can easily measure velocity at any spot.
Excuse me, sir.
And your gradient is?
Yeah, we have to conclude the session, sir.
This,
Next
okay?
speaker is.
So I will give you the, okay. I'll just show you something. Look at the peak of spectrum. It takes a long time to make to build up the whole velocity in aortic regurgitation. Okay, and then along with aortic regurgitation and aortic stenosis, you will get mitral regurgitation and mitral stenosis. You have to make a difference. You have to find a difference between the two, aortic signal and mitral signal. And then there's a continuity equation for us to assess what is the aortic stenosis, okay, or what is the aortic valve area. Is basically by continuous equation. You have a nice chart here, and by various means you will quantify your aortic stenosis. In atrial fibrillation also you have a little bigger problem. A problem occurs when in the second stage of aortic stenosis your left ventricle starts reducing in systolic function. That is the time you are losing your patient. That is the time you must spot to take that patient into a surgical hand. Okay, patient needs a valve replacement at that time. Okay, don't wait. The moment it crosses the 50, I would say this patient you should start tuning him. Yes, he should go in for valve replacement. Don't send him off straight. So you start putting it in his mind, and that is the time he will slowly accept it. Okay. All right. So I got lovely videos, but time is not for the others. Okay. Anything extra? That pressure recovery indication for surgery. Asymptomatic patient with abnormal exercise test. Okay. All symptomatic patient, you think of surgery. Okay. With dyspnea, syncope, angina, you think of surgery. Okay. And symptomatic patient with reduced ejection fraction, yes. But if the ejection fraction is too much, they may be beyond surgery. When you are doing another surgery, then you can also think of putting this man into a surgical interference. Yeah, I'm finishing. Yeah.
So the next speaker is online from Netherlands, and
Carry on. Connect him. Connect the next speaker.
can we connect the next speaker?
Connect
please?
it. Connect the next speaker. I know.
Sorry, sir.
Yeah, no problem. Okay. I know these topics are too vast. I hope I have given you. Yeah, she's already there.
Thank you, Dr. Naik, for
something to take home in this last 45 minutes.